Thanks everybody for joining us. I'm really delighted to restart the series again with Heart Trending, which is coming to you every third Thursday at 6 p.m. Eastern Time, 5 p.m. Central Time. Number one, I'd like to thank the FACET for making this happening again this year. It's going to be a new academic/educational year. We took a break for the summertime because there's some conferences overlap, but also people are off. So maybe give them a break from some education material. But we are coming back really very excited and have a big agenda coming in 2025, 2026. So far, we have 11 speakers lined up, talking about interventional, structural, peripheral, endovascular, and even imaging from invasive and non-invasive imaging perspective. Great faculty. I'm really privileged to be on the panel with them. So we're starting this year with Dr. Jay Widmer, who was joined the staff at Baylor Scott and White in Texas, an interventional structural cardiologist since 2018. I know Jay since we were fellows together. We went to conferences together at the Sky and other conferences when we were fellows. And definitely his career took off absolutely amazingly. And I learned a lot from him, and his career path has been phenomenal. He transitioned as a lead of the Heart Hospital McKinney and is growing and expanding in the Northeast section of Dallas Metroplex. I mean, for people who went to Dallas PCI or who have never been to Dallas PCI, definitely this is a meeting you should join. But he was presenting and doing live cases there, along with the amazing faculty from Dallas PCI. Dr. Widmer also achieved his undergraduate work at Southwestern University in Georgetown, Texas, and his combined MD PhD at Texas A&M Health Science Center in 2009. He was accepted to the clinical research track at Mayo in Rochester, Minnesota, and completed his internal medicine training in June 2012, general cardiology training in 16, interventional cardiology training in 18, and achieved all board certification. His interest currently is interventional cardiology, began in the research lab just before beginning medical school while witnessing a porcine cardiac catheterization procedure, and he had continued to mature as he begins a career as an academic interventionalist. His career kind of involved some change in his pathway as a digital health program for cardiac rehab, as well as implementation of both the feasibility and randomization trials to test the system. These projects have resulted in 120 peer-reviewed papers. I mean, I didn't talk to you about it, Jay, before, but definitely something I would like to learn more about, and hundreds of conferences and abstracts presented related to physiology and social media, digital health. He continued to be in his research role and expand during his role, but currently he is leading the program in One Full Hospital and focusing on a very important topic that most of us are really lagging, and we cannot have enough from this topic, which is coronary physiology. With that in mind, I would like to hand it over to you, Jay, to tell us a very engaging interactive presentation with case presentation related to coronary physiology and coronary flow.
Great. Thanks, Chadi. Thank you for having me. Thanks to FACET for setting all this up. And yeah, we've known each other for a while. Great career trajectory. So privileged to be sharing things here with you. So we'll go ahead and get going. We've got cases throughout here. So, please stop and ask questions about sort of what we did, why we did, because this is an emerging field. And I don't think that the workup, the diagnostics, the standards and the treatments are set in stone and guideline based, quite yet to the level. So there's a lot of moving parts here and there's a lot of cool things to come. So, just kind of going beyond the initial angiogram and why we do this, we really only see about 15% of the coronary tree when we're using conventional angiography or CTA. But what you see from, these microspheres that fill up the microcirculation, really the main driver is going to be the very small arterioles that we cannot see. And you remember that from medical school, that really drives the resistance. So we want to understand flow, and to understand flow, we have to look at pressure and resistance and use some terms to kind of make the calculations and the assumptions on that. So I like to start off with a case, and up in Rochester we had all kinds of second and third opinions, and I get to Temple, Texas, my first job in Central Texas, thinking I probably am not going to see any of that. Let me just get to work as an interventionalist. And sure enough, the second week, the wife of the chair of the pathology department comes to see me and says, "Man, I had all this chest pain and nausea and sweating. I was up in the mountains." And here was my ECG, and I said, "Oh my gosh, why did they take you to the cath lab?" She's like, "Well, I didn't want to go to the cath lab, so they did a stress test. I can't really explain that. She had troponin elevation." So she comes to see me, and I thought, "Well, here we go. We're going to the cath lab. We're going to fix something. This is going to be great as a young interventionist." And I take her, and she has no obstructive coronary disease. And I think to myself, wow, I really don't have anything here to help this lady or to diagnose this. And I don't know what happened to her up in Colorado. I don't know what's going on right now. She continues to have chest pain. And the reason this is so important, if you don't have these tools to diagnose and treat these patients, you really miss them, and you then struggle, as I did with this patient. And over the next 7 years, we struggled with atrial fibrillation, thyroid disease, mild cognitive impairment, and she's being worked up for a thyroid cancer at this point. And so, there's really a systemic problem with the microcirculation and the endothelium, and we really need to get to it. And the kind of the canary in the coal mine is going to be the coronary arteries. So if we can get to that, we could have potentially headed this off of the pass and really got aggressive with medical therapy. So that's why I think it's really important to go beyond the angiogram and to work to make a diagnosis. So if you look at patients who come to the cath lab with good reason, positive stress tests, angina, those types of things, about 40% of them are probably going to have non-obstructive disease. So then if you take that 40%, most of them are going to have some kind of coronary vasomotor dysfunction, with the predominance being microvascular disease and vasospastic angina. So just know that it's going to be a high diagnostic yield to then go beyond the angiogram and do the simple tests. And we'll show you a little bit about that later. And that's why this is so important, is this is not a one-off disease. This is not an orphan entity. This is a highly endemic situation you're going to see in the cath labs. And again, this is just one of my favorite images that Dr. Taketi did. She's up in Boston, and it just really shows the microcirculation and what lies beneath, and kind of the iceberg, the tip of the iceberg that we really need to study. So, we started to classify these patients. We looked at about 1,000 of them throughout training, and really the two components that we're looking at are endothelial dependent and endothelial independent. So we're looking at the response to adenosine, endothelial independent, response to acetylcholine, looking at the endothelium. And we tried to endotype these patients based on their responses, either normal or abnormal. And really, you can have a normal response, which is going to be about 25% of your patients when you take them to the cath lab and do this. They're going to respond. They're going to dilate to acetylcholine. They're going to dilate to adenosine. They're going to be able to generate flow. So that's good. We need to send those folks on out of the cardiology clinic, GI, musculoskeletal, pain, pulmonary, whichever the case might be. So then you're going to have your endothelial dysfunction phenotype. So these patients are not going to respond to acetylcholine. They're either going to have a constriction of the vessels, which would be kind of mild endothelial dysfunction. They're going to have chest pain without much change to the epicardial vessels, but maybe some ST changes and a lot of symptoms. That's going to be a microvascular spasm. Or they could have abject vascular spasm, epicardial spasm, where they really clamp down the LAD, and we'll look at some of that a little bit later. Then you can also have non-endothelial dependent reduction in coronary flow reserve, and that's a response to adenosine. So that could be from diffuse epicardial disease. It could be from structural microvascular disease, infiltrative cardiomyopathies, elevated LVDP, all kinds of reasons that you just cannot generate that flow reserve. And then you can have abnormal, and both of these are abnormal. And those patients are especially tricky to treat because it takes multiple agents, and you usually don't have the blood pressure reserve. So some abbreviations here to set the scene. You're going to see things like CAD, which we know, coronary flow reserve, CFR, CMD, index of microcirculatory resistance, or something with microcirculatory resistance. That's going to show how much tension there is down there, and resistance to flow. NOCAD used to be a term we used, non-obstructive coronary disease, and we moved on to INOCA, or ischemia with non-obstructive coronary disease, going through the Covetas criteria. And now we've taken on angina with non-obstructive coronary disease, or ANOCA, because about 40%, 30 to 40% of these patients will have a normal stress test, and we don't demonstrate any evidence of ischemia, but we do the testing and it's positive. So clearly they have angina with non-obstructive coronary disease, but they don't have demonstrable ischemia on a non-invasive stress test. Well, we know from data from the VA system that if you have some mild coronary disease, maybe not true obstructive disease, you don't do as well in terms of mortality over 10 years. Furthermore, when you look at patients from the WISE trial, big study out of Cedars and Mayo, if you go out to 10 and 12 years, if patients have abnormal coronary flow reserve or abnormal response to acetylcholine, they also have worse outcomes, primarily heart failure hospitalizations and angina hospitalizations, which when you kind of run the numbers, and I've looked at, and we'll look at some of this at TCT, probably is going to be on the order of conservatively $7,000 per visit, up to $12,000 per visit. So certainly cost implications there. Then if you take a step further and maybe not look at the hard outcomes, but Dr. Gulati had a great paper looking at some survey responses. And really, these patients will have a decrement of about one metabolic equivalent in their health, which will have impacts on their mental health, their ability to do their job, their ability to take care of their family, themselves, be in functional relationships. So the psychosocial and the physical impacts are also quite substantial. And if you start to run this thing out, then you're looking at anywhere conservatively $4,000 per year, up to potentially $7,000 to $8,000 per year impact with that reduction in productivity. If we're thinking they're going to lose maybe 1 to 3 days of productivity per month. And if we think that the total cost of this is about $21 billion to the United States, and if we're looking at the number of patients that we think have this entity that might not be fully diagnosed. So the implications are profound here across the board. So that's what I really want to impart on you, that we need to push and get beyond the initial angiogram. So coming back from kind of this sociologic and anthropologic assessment of non-obstructive coronary disease, I've recreated this graph from Dr. Gould's work back in the 70s when he looked at about 10 dogs, and he put occluders on the left anterior descending artery and looked at resting flow and called that 1, just to be arbitrary and just to be universal. And he says that we should be able to generate about 5 times the coronary blood flow with hyperemia if a dog is running to chase a rabbit or running away from a predator or doing something. So the same thing. Right now, my coronary flow reserve is probably a little bit higher as I'm presenting this, but you're sitting there at 1. You should be able to generate 5 times that. And the reason you should be able to generate that is because the coronary circulation is really only flow dependent. It cannot extract any more oxygen than it already does. Your lowest concentration of oxygen in blood in the body is going to be in the coronary sinus, because the myocardium is doing maximum work. So if you want to deliver more oxygen, more metabolites, you have to deliver more flow. So when Dr. Gould started to get these occluders a little bit more narrow down these dogs' coronary arteries, you get to about 70 or 80%, you start to see a decrement in that coronary flow reserve. And if you're wondering why we stent a vessel at 70%, this is the nidus for that decision as we sort of started to look at that in terms of ischemia and where it's appropriate to stent a human vessel at 70% occlusion. And then you see when you give it down to 90, 95% occlusion, then you can't even generate resting flow. And that's when you get the resting angina, unstable symptoms, and emergency department visits. So this concept of coronary flow reserve, the ratio above which baseline that you can generate in the coronary circulation, is a very important piece of information and a very important concept when we're talking about coronary physiology. If anybody has questions on this is a great time to ask them, because this is going to be key as we start to talk about some of these other concepts in physiology.
I'm waiting for questions, but Jay, I have a question for you. So now for the traditional busy cardiologist or interventional cardiologist, they come, this is what we see every day: chest pain, positive stress test, dermal coronary, go back to your cardiologist or go back to the clinic and deal with this kind of vasodilator, nitrates, referral to GI. So maybe we're going to cover it soon, but when do we consider, wait a second, we have to dig deeper. We have to send somebody who has center of excellence like yourself to dig deep into this problem. I want to hammer this question before we jump into how to do it, because this is, I think, the bulk of patients that are missed completely to be sent to the cath lab or to send to people like yourself, expert in this space.
Yeah, I think that's a great question. And I think that is a fundamental concept that we need to uncover. And, if you look at entities like the microvascular network, which we're a part of, and we're trying to we're trying to give an idea of when you can do this. And some of our colleagues, at MedStar will do this ad hoc, which I think you probably can do. But I think we need to start to develop the data set that shows, doing this ad hoc at any interventional center, which it's essentially an FFR that you're doing. That's the same concept and the same procedure. We could at least do a lot of screening on this. Or could we come up with some other modalities that we could use to kind of screen and say CFR is low or endothelial dysfunction is present? We have a diagnosis for you. Would you like us to treat you empirically, or would you like to see, a center of excellence and go see Dr. Trammell in California, or Dr. Samuels in California, or Dr. Lerman, or some of the folks in New York, DC? So yours is a great point, and I would boil it down to a couple of points. One, we need to make the testing very universal and very protocolized so that everybody's speaking the same language. That way it can be more universal and we can start to make the diagnosis almost on an ad hoc basis. Then, if the patient would like to, then a referral on to do a little bit more nuanced testing, and we can go into that. Did that make sense?
100%.
Great, great. I'm good, good. I'm glad that helped. So why physiology? If you go back to the old FAME study, our eyes are pretty good when the vessel is very stenotic or when it's wide open. But you get there in the middle, we don't have a good idea and we don't have a good sense. So I think that's why physiology is really important. And sort of, I know it when I see it or something along those lines. We really need to measure and we really need to be precise about this. And so here it goes back to that concept of coronary blood flow, coronary flow reserve, looking at the endothelial dependent using acetylcholine to test, and the non-endothelial dependent with adenosine. And if we can look at those two components and think about it in that realm, I think that's a nice framework. As we look throughout the coronary tree, we're looking at coronary flow reserve. So anything along the coronary tree can cause a decrement of coronary flow reserve. Fractional flow reserve, we're going to be testing in the epicardial stenosis, which we all do most days in the cath lab. And then the index of microcirculatory resistance and some newer indices are coming to look and see how much resistance there is in the microcirculation and how well that works. We know that if you have some coronary disease, like we said earlier, it's going to have poor prognosis in terms of mortality. And then if we look at just an abnormal coronary flow reserve, again, less than 2.3 in the WISE trial, and there's some debates on the cutoff, you're going to have more heart failure and anginal outcomes. And the same thing with regard to acetylcholine. If you have an abnormal endothelial response to either epicardial circulation or the microcirculation, also more heart failure and anginal episodes. So it's important to treat this from an outcomes perspective. If you're looking at the combination of the two, if you look at patients with low CFR and low and high IMR, so high resistance, either one of those is going to have an increased outcomes over the next 5 to 10 years. But if you put the combination of the two together, like we said before, very difficult to treat, they're going to have more outcomes when you look at the next decade of life. How we used to test this, if you talk to Dr. Gibson, see Michael Gibson, he used to look at myocardial blush. And if you have kind of a poor blush versus very good blush, and this was a very subjective entity looking at the blush of the myocardium. But this actually showed very good correlation with outcomes and was something we could do. It's just very subjective and tough to test. So we moved on to functional angiography there in the 90s, where we started to look at things like the Doppler wire, and we started to look at thermodilution then in the 2000s. We will hopefully have the Doppler wire here over the next year, and we can start to work into that. For now, we look at bolus thermodilution, and to some degree, continuous thermodilution, but bolus thermodilution, just like we do in a Swelling-Ganz catheter. And we're measuring the transit time of a fixed volume of saline going from the guider to the sensor that is distal into the LAD usually. And that transit time is roughly equivalent and inverse to the flow. And so if we have a transit time at baseline, if we have a transit time with hyperemia, which is going to be lower because the blood's moving faster with hyperemia, that ratio then will give us our coronary flow reserve. So this just goes into that a little bit more. If you see on the right, that's a Doppler signal. You see at rest, you have a low Doppler signal, obviously in diastole when the coronaries fill, and then that spikes up when you give adenosine intracoronary. Here, we're looking at an injection that with both rest and then with hyperemia, and this sort of difference in this transit time and the ratio is what's going to give us the the approximation of flow down the vessel. And so what gave us the data to say, yes, we should actually go and test this? And when did this boom in microcirculatory research really take off? And it was with the Core-MICA trial back in the late 2010s, when a group out of Europe looked at 150 patients and randomized them to either usual care or doing invasive functional testing and then going on and treating accordingly. And when you did that, the patients at 1, 6, 12, and now we have 2 and 5 years, they do much better in terms of quality of life, angina, and now even hard outcomes we're seeing. So from that, there's a Class 1A indication in the European guidelines, and we have a Class 2A indication in the current chest pain guidelines, recently published there in 2022. There's also a 2A indication for stress PET, stress MR. These are a little bit trickier to come by, and they're not as widely available, but everybody has an FFR system in their lab or has the need for an FFR or resting physiology. So this is something we can do to look at both coronary flow reserve as well as microcirculatory resistance. And we'll go through the steps to this. And so when you're saying, well, this is pretty esoteric, Jay, and you're kind of looking at some of these things and these patients with non-obstructive disease, why don't you just put them on calcium channel blockers or nitrates and call it a day? And well, I think that you can use this to tease apart other patients and other disease entities. And we saw a young lady who was having chest pain and was being treated with a tyrosine kinase inhibitor for metastatic adenocarcinoma of the lung.
Recording in progress.
She developed a pulmonary embolism and reduced ejection fraction. And so the CT scan you can see there showed a pretty hefty chunk of calcium there in the LAD. So they wanted us to see if we could stent the LAD and improve her coronary function and improve her ejection fraction. Well, I'll save you the radiation because I don't like it any more than the next guy. But you see here from these stills, there's not much doing in the coronary circulation. There's not much obstructive disease. So this is a non-obstructive disease entity with patient with reduced ejection fraction and some form of chest pain. Well, when we took her to the lab, all I had was the RADI system at that point. So I cobbled together with old parts this RADI wire that looks at thermodilution, which is a precursor to the CoraFlow. And what we did is we did the baseline you see down there, the transit times and the hyperemic transit times. And really, her coronary flow reserve her PDPA was lower and her FFR was almost borderline despite, normal coronaries. And when we looked, her coronary flow reserve was very good, almost 5, and her index of microcirculatory resistance was quite low, which was good. So now what to do? And now what are the thoughts? Well, our thought at this point, I'm happy to take any thoughts or any questions from the audience, so feel free to interrupt. I can't see the chat, so you just have to, Chadi, you know how to interrupt me, so go for it if you need to.
100%
But our
no
thought
problem.
here is this is not a microcirculatory issue. This is a tyrosine kinase inhibitor issue. And we changed her chemotherapy. We got her on the right drugs. We got her on the right medicines. And her ejection fraction improved. Her symptoms improved. And she also went into remission. So we were able to really change her therapy with this. Similarly, we had a very, very similar case, just not just a couple months later, a very similar angiogram, but her indices were much different, and their coronary flow reserve was much lower, and her index of microcirculatory resistance was much higher. So she really had an issue of the microcirculation. So we kept her chemotherapy as is. We tweaked some of her medicines, including adding some nitrates, some calcium channel blockers, and she started to feel better. Her ejection fraction came up, and she did quite well. So I think this is a good way to teach that physiology can really help to guide some of the therapy on this. So how we do this, it's the basic entity that Abbott and some of the thought leaders have come up with is called cath-CMD, that goes along with the MLD max, it's kind of in parallel with that. So you want to engage the catheter, you're going to advance the wire, distal LAD, distal 2/3, get your transit times at rest, give hyperemic agents, and then look at your coronary flow reserve, your IMR, and any other data that you can get. So you can see the catheter being engaged, the sensor going about 2/3 of the way down the LAD, just like you would a normal FFR or RFR or IFR. You get your transit times at rest, transit times with hyperemia, and then you can come up with your coronary flow reserve and your resistances. So this gives you a good idea. You can see this shouldn't take very long. It should take about 5 minutes to do the basics to get some baseline answers. So this is one of our superstar fellows. He's giving actually intracoronary adenosine here, which we have validated and tested, and we have published on. We'll show you those. And he flushes it down. You'll see in the background, that's the CoraFlow system that's going there, and it shows that the transit curves. He has very good transit times. We're using the assist system here. You can use a manifold. And you see that it says, wait, wait, wait. When the yellow box is there, it'll turn green, telling him to inject, and he injects, and he gets a nice thermodilution curve. We'd already attained our resting curves. These are the hyperemic. And so from there, we were able to go ahead and diagnose this lady. She had a reduced coronary flow reserve, high microcirculatory resistance, and she had quite a bit of microvascular spasm with acetylcholine. So very classic CMD case. And you can see the distance of the wire tip just down there. So it's about 2/3 of the way, just before the vessel starts to get really tortuous in the distal LAD. And the second part of this is going to be the endothelial dependent portion of the testing. So we'll go ahead and give adenosine, do that portion of the test, give graded acetylcholine, 20 micrograms, then 100 micrograms, and sometimes up to 200 micrograms. If it's a male down the LAD and you are convinced, it's a Japanese smoker with spasm and you just haven't elucidated it, you will get some potential narrowing or spasm. You can use your fluoroscopic system to measure the change in stenosis. And then we'll go ahead and give nitroglycerin and see everything recover. And not only the patient's chest pain resolve, but also everybody in the lab, their chest pain also resolves. So this is an important second part of the test. Not every lab will be able to do this, but this is not tough to set up, and I'm happy to help walk you through it and work with your pharmacist to help with this. And then I would be remiss if I didn't mention myocardial bridging. Certainly, this can be found probably up to 40 to 50% of patients we take to the cath lab if you look with intravascular imaging. And a lot of the times the CT will miss it. With myocardial bridging, you'll have a muscle bridge that covers over the LAD, or we've seen it in other vessels in the circumflex and in the PDA and so forth. During systole, this will compress the vessel. And you said, Jay, that shouldn't matter because the vessel fills in diastole. To get super nerdy about it, there are multiple filling waves and electromagnetic waves that go down the coronary artery. The bridging interrupts the forward compression wave that then disrupts the backward suction wave that allows the vessel to fill during diastole. So we've proven in Justin Davies and some of those really smart coronary physiologists have shown that this disruption occurs. So there's scientific proof and reasoning behind why bridging will impair myocardial blood flow. Plus, you'll get some endothelial dysfunction distal to the bridge, and we'll show you a case on that a little bit later.
And Jay, stop you here for a second. So we see sometimes myocardial bridging on clear angiographic epicardial disease, right?
Yes.
But is this something we should further investigate if we see bridging to see if this is causing ischemia with these testing, or just by showing the epicardial squeeze during the systole is enough?
Yeah, I think that's a great question. I have started to do more imaging on these and looking at the myocardial bridge index, which kind of looks at the length and the depth of the bridge, to then kind of go back and see what the implication on the reduction of flow is. I always start all of these cases by doing an RFR. And if that RFR is positive, but the vessel looks open, then I have a high suspicion that there's probably a bridge, and that's probably functionally significant. If the RFR is normal and the IVUS doesn't look bad and the CT doesn't look bad, then we will go on and we will do resting, and usually dobutamine, sometimes adenosine or atropine will be used to get this hyperemic FFR that we will then look in diastole to see if that ratio during diastole, during maximal heart rate, because that's what we're trying to stimulate, is the heart rate to maximize the bridge. If that ratio drops below 0.76, as demonstrated in Dr. Eskenon's work, then that's going to be functionally significant.
Yeah.
So we will then go and use beta blocker, calcium channel blocker to slow them down to mitigate the impact of the bridge.
On the table?
I send people on to surgery, because as you'll see in a later case, these people will usually have endothelial dysfunction. So the bridge might be unroofed, and they might not have that issue, but they might still have spasm and endothelial dysfunction. So you will have opened their chest and they still have chest pain from a coronary perspective. So it's got to be a really good case, and you got to have a really good surgeon like they do at Columbia and Stanford. So very long answer. So I'm sorry for that, but it's a very intricate disease process.
When you say calcium channel blocker and beta blocker, are you saying you give it on the table with the patient on the table and
No,
you study it, or
use that to treat as an
oh,
outpatient. I think
yeah,
that that's an interesting concept that you bring up. I've submitted a couple of things, but I think it would be interesting to look at individually, how do the patients do and how do their indices respond. That's a really good point.
yeah. There's one more question about the slide before about working with the pharmacist. So apparently there is some preparation required to work with the pharmacy department to make sure these medication are ready in the cath lab. Do you have like a minute just to elaborate on what is this requires and in terms of coordination, if somebody would like to launch a new program?
Yeah, so if you in the couple subsequent slides, there's a really nice white paper that we had in Jack. It was two-part series on kind of the diagnosis, the workup, the cath lab, and then the treatment of non-obstructive coronary disease is put out by the Microvascular Network. And in that, it does detail the preparation, which is really quite simple, and it was really championed by the folks at Stanford, Doctors Fearon and Trammell. And what you use are what's called mycol, and it's this powder or drop formulation of acetylcholine. It's supposed to be ophthalmic. We use it off label, and what you can do is put that into a liter bag, and that will essentially give you the uh, the dilution where you can then put that, and that would be a one in I believe it's 1 ml per 200, 1 ml 200 mics. It becomes the dilution. So if you have that bag out and you create that bag, you can draw it up and aliquot it out on a per patient basis. So when we'll do 4 and 5 cases in a day, we'll have a pharmacy mix up the bag, aliquot out for everybody, and then we have plenty, and we don't have to use one vial of mycol per case, which that's why we run into shortages. Most of the times, pharmacy is going to want to do this for you, and they will send it to you. That's what takes about 30 to 40 minutes, why it makes it tough to do it ad hoc. But some labs are able to actually prepare it and then keep it in their cath lab Pyxis. And if you can get that with your pharmacy, then you can mix it up on the fly and away you go. So there are a couple of different ways to do it. There's some nuances, but really a very easy preparation and one you can just put in that nursing folder along with all of your other drugs in the cath lab.
Yeah. One more question came. The WISE 10-year data showed lower event-free survival when CFR is less than 2.3.
Yes.
Do you think CFR should be used as a prognostic biomarker even outside the cath lab, for example, via PET-based flow quantification?
Yeah, that's a great question. And we are you starting to use more CFR PET. Now the cutoffs are going to be different depending on the sequence and the machine that you use. But I think that could be equally because those data are or those metrics are derived from similar physiologic principles and indices. So they do match up. The exact one-to-one translation is not quite the same. At our institution, it's a myocardial blood flow reserve of 2 or greater is normal. So you just have to make sure that you're translating apples to apples on that. But I
Mm.
will use PET, especially if patients, maybe they had a bad experience in the cath lab. Some of these younger females, you go radial, they get spasm, they don't want to go back. And if we say, well, let's try a non-invasive thing and see if the coronary flow reserve is abnormal or not, at least as a starting point. It's not going to tell you if you have any kind of spasm or endothelial dysfunction, but it is a good non-invasive surrogate and certainly part of the guidelines.
Great. I can't wait to see your white paper.
Oh, there's plenty of stuff. So this is part of the pathway for diagnosing and diagnosing and then sort of endotyping patients with a NOCA. And so they come in, you have to exclude obstructive disease. It doesn't mean they can't have endothelial dysfunction or low coronary flow reserve with obstructive diseases. Certainly, I test many people who have had stents in the past. Who knows? Did they stent spasm, or do they have both entities, obstructive disease and also non-obstructive disease? But anyway, you go through and rule out anything that you need to fix with balloons and stents, or drug-coated balloons, or whatever or bypass. Then you go on to the coronary function testing, looking at your coronary flow reserve, moving on to the acetylcholine testing. We don't have a sense for the order of that. And I think some of Samit Shah's work up at Yale with the Discover Anoka, I think there's some other studies coming out that are going to show sort of here are the nuances to know depending on what you do first. But right now, there is no consensus on which one to do first. You do whichever you think. If all of those are normal, or if you have a high index of suspicion for bridging, then certainly dropping the IVUS catheter. I think it's tougher to see with OCT. I'm sorry, Abbott. It's tougher to see bridging with it. It's easier to see it with IVUS because you can kind of move it back and forth. And then you have your endotype, and you know if you're dealing with pure microvascular dysfunction, spasm, endothelial dysfunction, epicardial spasm, or some type of other myocardial bridge, or maybe even non-obstructive, maybe even non-coronary, non-cardiac chest pain. And this is just a little homage to the Doppler wire and kind of something that we'll see. But really, you get a couple of different data points when you have the Doppler wire there. And the difference here is that the Doppler sensor is on the tip of the wire differently than any other pressure wire, physiology wire that we currently use. And that sensor is then on the proximal end of the radiopaque part. But you infuse acetylcholine through the infusion catheter, and you get the impact of the acetylcholine there at the Doppler, but you also get an idea of what's going on with the diameter distal as well as proximal to tell you if your flow-mediated vasodilation is occurring at a proper rate or reaction, as opposed to what you think should or shouldn't be happening. So I think that that's an important piece of information, and hopefully we'll be talking about that in about a year. So once you have your endotype, the next set of this white paper then goes in and talks about what are some of the treatments. This top row is fairly well validated with probably small randomized trials of 10 to 20 patients, and then or maybe some larger observational studies. But this is a good resource for it. And then note that, and we'll go through some of these treatments and some of the other the experimental therapies that are going on. For our experience in Temple, when we had we looked at about 200 to 300 patients, and we found that really beta blockers and almost spironolactone showed the best event-free survival with ACE and ARBs coming in fairly close. Calcium channel blockers, interestingly, did not, which would go then with the EDIT CMD data. And then just a quick portion about where to put the wire. So you see here this vessel, and you can see you can put the wire either sort of in this distal 2/3, or you can bury it in the apex. And this is the same vessel, same patient, and just different wire positions using the same exact protocols. And you can get a coronary flow reserve and an IMR that is borderline, or you can get a coronary flow reserve and an IMR that are abnormal. So the distance makes a difference. And if you can kind of see there's a little bend in the vessel here. If you put your physiology wire down here, this probably straightens this out and makes it kind of a pseudostenosis. So just it's important to do kind of that resting index before, so that you know that you haven't artificially made the patient ischemic by straightening the vessel out with pseudostenosis. So, and these data are published in CRM about a year or so ago.
Yeah. There's a question coming as you're doing this, kind of related, is about access, because you're saying medication and stuff. Which is a good question. Access site, radial cocktail, and what radial cocktail do you use? Radial femoral, and if radial, what cocktail you use?
Yeah. So no cocktail in the radial. We think anecdotally, talking to Bruce Samuels, Jennifer Trammell, some other folks in Chicago, we think that no cocktail and sublingual nitro likely allows you to get the procedure done and probably doesn't have a big impact on the outcomes. We know that the calcium channel blocker sticks around and it will impact the outcomes. So if you give verapamil in your cocktail, it's going to be really tough to do an ad hoc study and know that you're really getting something that's going to be worthwhile and going to be reportable. If I'm planning this, I do it femoral. I'm very pro radial, but I do this femoral. I'm able to use a closure device at the end. I can get up, I can get around. It's very tough to try to navigate sometimes very small arteries in the radial, brachial, axillary. Try to get your, the acetylcholine and everything else done, and the tortuosity, and the patients in discomfort and their spasm. It turns it into a very difficult experience. So if I'm planning, I will just go femoral to try to avoid this, unless there's just absolutely nothing I can do. Then again, I might use a 5 French guide and a sublingual nitro and see what I get.
There's one more question about, we're talking about microvascular circulation. How about if somebody comes with high EDP and then we lower that EDP, whether with afterload reduction or diuresis, would that affect the microcirculation?
Yeah, absolutely. That's a great question. And so one of the endotypes that we'll see is kind of this isolated index of microcirculatory resistance, which is elevated. So I start every case. I say I should start every case with a resting flow. Actually, the first thing I do is an LVDP, and then I shoot the right. And then when I move over to the left, take the pictures, clear the guide, and then do a resting index. So if they have a high LVDP and their resistance is high, but everything else looks normal, I know that if I can give them something like spironolactone or another diuretic, get that LVDP down, they generally feel much better. So
Mhm.
yeah, so it will impact, but it's not gonna mess up your indices unless you're trying to get an FFR. It's not gonna mess them up, but it's gonna tell you why they have a high IMR, and you're gonna be able to do something about that LVDP as an outpatient.
Great. Thank you.
So, quick plug on IC versus IV. I think that you can do IC. I wish that Abbott would try to run this through because I think it's going to be important as the Doppler wire comes out. So, if you want to talk about IC, you have to do it very quickly, but it's doable. And you saw the video of us doing it. So, I think this is going to be an important fold into things as we try to get this more accessible. And these data were published in American Journal of Cardiology 2024. You can see really not much of a difference, IC/IV for all the indices. And then nitro pre or post, these are data we published at Sky, and we've got a trial going on right now. You can really see where there's quite a bit of change with intracoronary nitro with regard to the coronary flow reserve and the transit times at baseline. And so that will throw off your coronary flow reserve and some of your resistance reserve ratio as well. So this is an area under further discussion, debate and discussion. So we tend to give no nitrates before, and this is why. But I think that this is not a solved issue. And these are some data we're going to present at TCT using ChromaFlow to potentially predict coronary flow reserve. The change you see kind of in this first one up here on the left, kind of a change from a little bit darker red to a very bright red. This coronary flow reserve was 5. If you look here on the lower right, there really is no change and kind of a degradation with the infusion of adenosine, and this person's coronary flow reserve is only 1.5. So potentially another use for ChromaFlow, and we'll present these at TCT. So hopefully more to come there. In terms of treatment, it's kind of a rough go for the past few years. The Warrior trial was negative, but of course there were problems with bias and selection and sort of the identification of the cohorts there. So we know that maximal medical therapy doesn't help. The EDIT CMD trial showed that potentially calcium channel blockers don't have a benefit. We can get super nerdy and talk about protein kinase C, G-link proteins, and some of the other Rho kinase pathways if you want to. But I think there are going to be responders to calcium channel blockers and they're non-responders. And it's fairly easy to tell within 2 weeks once you started if they're going to respond or not. That's the punchline. But treatment with calcium channel blockers can be tricky. Coronary sinus reducer is currently undergoing a single arm study now. Looking at this, Dr. Alame has also done some randomized double blind stuff, and it appears as though coronary flow reserve might improve with this. So I think there's more to come on this in both obstructive and non-obstructive disease, but this won't be for everyone, and this is not a panacea or a silver bullet, but certainly interesting, and more of these Me Too devices will be coming out soon. CD34 stem cells, as well as VEGF analogs, have shown very good promise and are now entering phase 3 trials. So hopefully that will be something that will be on tap here in the next 5 to 6 years. And then a non-invasive therapy, EECP, in our neck of the woods, that's called flow therapy. But there are some good benefits, and there have been some studies, small studies, observational studies, showing that there is a reduction in symptoms and an improvement in a reduction in angina and an improvement in symptoms and quality of life if patients do 5 sessions per week for 7 weeks. Now, obviously, that's a big ask, but if they don't want to take a lot of medicines or maybe their blood pressure doesn't tolerate it, I think this is a very viable option and something certainly you can present to patients. And if you say, why don't we just give them calcium channel blockers up front? Well, these data from Dr. Lerman and cohort when we were up at Mayo showed that really if you do the reactivity testing up front, you're going to save on the order of $20,000 to $25,000 in terms of resource utilization. So it behooves the patients in terms of time, money, and also the healthcare system. Let's answer the question. Let's get them diagnosed, and then let's start therapy, because it's much easier and cheaper to switch medications or go to ECP as opposed to more stress tests, more PETs, more caths, more this, more that. Here's some of the information in terms of CPT codes, the reimbursement, the RVUs. So this is a lucrative. I mean, you're not going to buy a yacht with it, but this is something that you will get reimbursed for your extra time and your extra work. So don't think that this is all for charity. I think that this does the right thing for the patient, but I don't think you're going to go broke if you enter into this on a couple of times per month, and it should help time and money. And then this other case is kind of interesting. We talked a little bit about, this guy had been stented a bunch of different times. This was about 10 or 15 years ago. I guess 15 years ago, 10 years ago, sorry. And he came to us and we thought that we were going to stent something, and we did the coronary reactivity testing, and you see down here, he just really loses his LAD. And that's just below the stent, a prior stent. So he had very, very diffuse epicardial stenosis and spasm. So we put him on calcium channel blockers and L-arginine, and he did quite well. So this doesn't mean it's just the clean, pristine coronaries that we have to think about, but patients who have stents and we think that we've done everything correctly, there might be another entity at play here. And then the last case, we talked a little bit about myocardial bridging. Felt really bad. I had to reschedule this lady. We had some difficulties with scheduling as I'm starting a new job, and there were some communication gaps. And so I moved around some admin meetings on a Friday. We did her case, and she has really normal, clean coronaries and kind of atypical symptoms. But you see that really long segment right there in the middle of the LAD. Well, when we went to do the bridging test and assessment, she did have a very significant myocardial bridge, and you'll see just below that quite a bit of spasm. And she goes, these are my symptoms. And so we got her on the right medicines, and she's actually done really well with nebivolol, which is kind of a nitric oxide donating beta blocker. Beta blockers, we think, tend to potentially enhance spasm, but actually with this nitric oxide donation, as well as slowing her down from the bridge, she's done quite well. And she's gone from a CCS class 3 or 4 down to about 1. And she's a much happier person. She's just a sweet lady. And she was very, very appreciative that we could give her a diagnosis that she had sought for so many years. So very rewarding practice as well, and good to help patients. It can be kind of troublesome to go therapy by therapy until you hit the right one, but it does feel good when patients are much more functional and kind of get out of that psychosocial funk, and we're able to give them a good diagnosis and therapy. So in conclusion, coronary reactivity testing is guideline directed. It is something that is cost effective, and we're going to see non-obstructive coronary disease in multiple flavors throughout our interventional and non-interventional careers. So we do the endothelial independent, the endothelial dependent testing, and then if we really need to, look for myocardial bridging. And this testing improves quality of life. So happy to answer any questions about sort of the ins and the outs and some of the nuances, or I think, happy. That's a picture of the new shop up here in DFW. Happy to take any emails or phone calls, texts, whatever you guys have. And really thank you for having me on, and thank you for your attention.
Thank you so much, Dr. Widmer. There's one question coming. Let's see. In patient with myocardial bridging, what is the relationship between the length of myocardial bridge and CFR and IMR?
So that's a great question. I don't know that we have data on length of the bridge. There is no relationship between the bridge and the myocardial resistance, unless they also have microvascular endothelial dysfunction. So 2 different entities. But the length of the bridge and the CFR, if it's a very long, very deep bridge, then the CFR is going to be abnormal. But I think you have to have a very severe bridge before you start to see something in terms of abnormality of a CFR. And that will be a very lagging indicator in terms of the severity of the bridge. So you're really looking for your resting index, either IFR or RFR, being abnormal at rest, or your fractional flow reserve, FFR, being less than 0.76 when you give dobutamine or sometimes adenosine.
What's your preferred medical therapy for someone who has mixed myocardial bridge and vasospasm?
Yeah, so I've started to use nebivolol. I have some data for that over and above atenolol. If they can't tolerate a beta blocker, which some people don't, and some people don't like beta blockers, and sometimes the nebivolol will give people headaches, and I can't quite explain that, but unless it's just the nitric oxide component of it. But I really try to slow them down then with a calcium channel blocker. Diltiazem tends to be kind of the middle of the road beta blocker in terms of slowing the heart rate and providing vasodilation, and a little less abrasive than verapamil, because we will run into side effects with verapamil and it will have some drug-drug interactions. So diltiazem, probably if you're going calcium channel blocker, um, and then either atenolol, which does have some good data in microvascular disease in terms of symptoms, and then or nebivolol, which potentially could be better than atenolol based on some small randomized data and some other observational data.
What's your dose, Jay, for the nebivolol?
I start at 5 usually.
Mm,
You can go down to 2.5 if they can't tolerate it, and then going up to 10. But I
mm.
usually kind of start middle of the road. For diltiazem, just depends on their heart rate and their blood pressure, but I usually start low and then kind of ramp up. The tricky part with diltiazem is it's capsules. So I only give them 30, just so they don't end up with, 90 big stacks and 90 pills of 180, 240, all these other things. So yeah, I usually start kind of middle of the road and work my way up.
Long acting, right? Long acting.
Yes, long-acting
Cardio, cardio,
diltiazem. Now, I have
diltiazem.
had patients who I've put on long-acting diltiazem. Their heart rate is still high. I'm a little reluctant to put them on a beta blocker, or they don't tolerate a beta blocker. And I have given them PRN diltiazem, the
Mm.
short-acting, and they kind of use that as a rescue over and above nitroglycerin. And I have had some success with that. So as long as their heart rate and their blood pressure can tolerate it, that gives them a little safety blanket, a little peace of mind. So I have had success with that.
There's a question more, and it's going to take some time, which is review the medication and different pathways. But I think this is kind of going to be very extensive. But I have a question ahead of that. Let's say a patient come to me, angiogram is normal. I suspect endothelial dysfunction. I give them calcium channel blocker, and then I refer him or her to you. Do you give them a washout period where tell them to stop your calcium channel blocker and then come to the lab to test you?
Yeah, great question. Try to stop all vasoactive agents 24 to 48 hours prior to, so that there's no interference. And in the meantime, I usually give them nitroglycerin tablets and say, listen, lay low for a couple of days. You might not feel good, but we got to wash everything out to have a true test. And usually most folks do quite well.
My comment is about treatment pathways. I mean, if you can put them in big kind of buckets for us, what medication use?
Yeah, kind of big bucket therapies, anything with microcirculatory dysfunction, calcium channel blockers are a pretty good way to start. And most people do quite well. I had a young patient, he's actually an F-35 mechanic. So I can't do video visits with him because it's top secret where he is. I called him today. He's like, Doc, I feel great. This is amazing. You just hear all these like planes and jets overhead and stuff. And he did really well with the calcium channel blocker. Similarly, the next person I saw, she did terrible with the calcium channel blocker, and she's having palpitations. She feels terrible. So she might be one of those non-responders. So, but anything with microvascular disease, calcium channel blocker is where I like to start. If it's a bridge, either calcium channel blocker or beta blocker, and we talked about those options. If it's pure spasm, and if it's epicardial, that if they tolerate nitroglycerin, then any of the nitroglycerin preparations, IMDR, the patches are quite successful. There's a little bit longer acting one, Isordil or Nitrotime are very good. And then if they can't tolerate that, then sometimes amlodipine, then moving on to diltiazem. And then kind of as an adjunct, L-arginine works well for spasm, both in the microcirculation and the epicardial circulation, as it's a precursor to nitric oxide. You have to give about 4 to 5 grams twice a day. So it's also a dietary supplement because they're full after they take all the pills. And maybe that's the key, is they lose weight, but that's kind of something that falls under that. I'm trying to think if there are other items or entities. And then ranolazine can work for a mixed bag of these. I don't have great rhyme or reason for when that will work. Spironolactone for high LVDP and isolated elevated index of microcirculatory resistance. And then ECP tends to work pretty well in patients who can't tolerate any medicines because their blood pressure is too low. And what we see is actually their blood pressure starts to go up just a little bit. So instead of being, 105 over 72, their blood pressure actually comes up more like 110, 112 over 80. and they start to feel better. And then you start to use some lower dose nitrates if you need to.
It's great, Jay. There's one question came, we have 1 minute, is about if somebody has going radial, has radial spasm, and you cannot kind of have spasms, you don't want to give cocktail to affect the vasodilation. Is there a role for long sheath, radial sheath, to bypass that, especially in older women?
Yeah, absolutely. You can use either just the the longer 25 centimeter, the R2P sheaths. Certainly those can be used if you can get everything in and down. That's absolutely fine to do. I don't know that I would use the sheath to cannulate the coronary. You still use your guide through there, or I've used a 5 French guide in the past, using either mother and child or balloon tracking to get up through the vessel.
Perfect timing. End of the webinar. Thank you so much, Jay, for an amazing presentation, amazing overview. We're going to be having a series of these lectures coming, as I said, every third Thursday, focusing on physiology. But this is kind of like I would say, this is a textbook lecture of physiology. This is a recorded session. It's going to be posted on the FACET.org website. So once this is live, we're going to be posting on social media and also send it back to the mailing list that we have. So everybody signed up, please. Don't forget to collect and pick up your CME activity. This is a 1-hour CME given from you from FACET family, Katie Hobbs and teams. Thank you so much for your work. Dr. Widmer, amazing talk. Thank you so much. I'm really inspired to the level that we are putting, sure, I'm going to promote something else now, putting a physiology session for Sky First. So if you are interested and you are in Detroit market or in Detroit area, we are putting together this webinar. It's a Sky First, which is focused on fellows, a case-based discussion about intravascular imaging and physiology guide from different systems, Henry Ford, Detroit Medical Center, Beaumont/Colwell, and also University of Michigan. Dr. Widmer, cannot thank you enough. Amazing work, amazing presentation. Cannot stop learning from you. Thank you for your time, and have a good night, everyone.
Thanks, Chadi. Thank you for having me.